Hi, everyone. Guess the microphone's not working. I don't know that it's this one. So I'd like to introduce Kimberly Page. She is coming to us from New Mexico, where she's a professor of preventive medicine and biostatistics at the New Mexico Health Sciences Center. Kim is an infectious disease epidemiologist with significant experience conducting cohort studies, clinical trials, and implementation science research. She received her PhD from University of California, Berkeley, where she was a faculty member at the UC San Francisco for 20 years. She is a nationally and internationally recognized HIV and viral hepatitis prevention researcher, and she's going to talk to us today about hepatitis C virus and her research in risk and disease differences.
That's really good. I sent Cassandra a copy, but I think it was fixed. This is like the one that I have on me. I do. Yeah. Wow. So I'm also pleased to be here. Thank you all very much. And we'll just fix this. Golly, that's embarrassing. Yeah, I did send one to Cassandra that was fixed. I went through it. I'm teaching a small seminar right now in grantsmanship to there's 5 residents. And so I'm at an academic medical school, and most of my teaching and mentoring is in the context of physicians and residents, junior faculty. And I took a few steps back after the first couple of classes to kind of remember what it's like to put a team together and really put a research team together that works, and what does that take. And we had some new pilot awardees come in, and their message wasn't so much about their study question, it was how they needed to put a big team together. And I realize now, wow, this is going way beyond the team of one research study. I'm going to tell you a little bit about this study that I started called the International Collaboration of Incident HIV and Hepatitis C in Injecting Cohorts, and I'll be calling it the InC3 study. So what is hepatitis C? It's a really cool virus. It's a small envelope virus from flavivirus. There are 7 genotypes globally. It's a single-stranded RNA virus, which means that when it gets into its tropic cell, it reproduces very rapidly, and it, just goes crazy. So it's very hard to control. 25% of people who get infected with hepatitis C spontaneously resolve the infection, so that's like self-cure, although that really varies by sex and interferon lambda 3, also known as IL-28B, and I'll be telling you a little bit about that today because my group was very instrumental in showing that. Chronic infection leads to cirrhosis. The liver is a very forgiving organ, and so infection takes a really long time to cause significant disease, 20, 30, or more years, and it can also cause hepatocellular carcinoma. Hep C is the biggest reason for transplants right now in the United States. In the United States, we have 3 to 5 million people who are infected, depending on who does the analysis, and globally there's over 70 million people. There is now up to a 95% cure rate with current direct-acting antivirals. There are some people who believe that we can eliminate hepatitis C by curing our way out of it. I'm not one of those, but I will say I am if it gets me money. And I will also say that there is no prophylactic vaccine, and we have just completed the first vaccine trial. And the data is being locked as we speak. So I don't know the results of that yet, but a preventive vaccine would go a long way. It's a whole nother talk to describe why we don't have a preventive vaccine, except that these people who spontaneously clear give us the information about how the immune system responds, because, and that's the only thing we have, so a vaccine will probably stimulate, or right now most vaccines are aimed at mimicking the immune response so that people clear virus, not to prevent infection. This just shows you a little map of where it's mostly located, and you can see the red spots, in particular up here, and there may or may not be a pointer. That's okay. But up in Egypt, it's well known that it's a high hotspot. Mongolia has a lot, the Republic of Georgia, and certain parts of sub-Saharan Africa. But it is all over the world. In the United States, we have two very distinct epidemics of hepatitis C. First, we have the baby boomer birth cohort group. People who were born between 1945 and 1965 have a higher prevalence of hep C than any other part of our general population. People born during these years are 5 times more likely than adults in other birth cohorts to be infected. And there's many reasons for that, including widespread blood transfusion, but we have the magical 60s take off and drug use expand. And for many reasons, many people got infected. And because it's a silent and really not debilitating disease, many people, half the people at least, walk around infected and don't know that they have it. So, and that, I am in the baby boomer cohort. We now have guidance to test everyone in that cohort. In addition to our risk groups, I've not been asked one time by my provider to get tested. So that's what happens. It's, again, the leading cause now of liver cancer. Hepatitis C deaths now exceed deaths of all other reportable infectious diseases, some combined in the United States. So we have a very high amount of mortality, which is actually explained why we've had some declines in the population prevalence in the last 10 years, which is kind of sad. But now we have these great drugs, and we're trying to get people to them. But the second epidemic is in people who inject drugs. And in 2014, it was estimated by the CDC that over 70% of new infections were as a result of parenteral exposure. It's a blood-borne virus. It's not spread through kissing. It's inefficiently spread through sex. It's really about blood-blood contact, and that's how it is spread. Right now, in the last 3-4 years, we've seen increases in the reported cases of acute hepatitis C to the CDC, and this increase has been mostly in 24 to 35-year-olds or 25 to 34-year-olds, and it's really associated with the expanding opioid crisis that's been happening in the United States. So besides injection drug users, hep C disparately affects other groups who have high blood exposures. People living with HIV/AIDS, 1 in 4 people are co-infected, and among those who've injected drugs, over 50% are co-infected. Incarcerated individuals, this isn't because they're getting hep C in jail. People with a history of incarceration often have a history of drug use, and when you test that population, you'll find a high prevalence, ranging in the United States from about 9 to 41%. And that's at entry into jail. So homeless people, 22 to 37% of people who are unstably housed have hep C. And again, this is associated with blood exposure, but these are disparately and medically underserved populations. And veterans is also high too, especially the baby boomer veterans, where prevalence is estimated at 5% overall in the VA and over 12% in homeless vets. So these are all populations. The VA is doing a great job right now of rolling out universal access to the new drugs, so they're getting a really high cure rate and reducing mortality in liver cancer. It's really remarkable. Those increases that I mentioned to you that started a few years ago, they really have taken off, and this is last year's data. The 2017 is, I think, just coming out, but it shows you that we've actually had a 300-fold increase in hepatitis C in the United States in the number of reported acute cases. Acute hepatitis C is detected in about 5% of cases. Literally the tip of the iceberg. So it's mostly an asymptomatic disease, and you get it and you don't know you have it. It's not like hepatitis A where, we've got people turning yellow, but some people become icteric, but only 5% of people show symptoms. It's highly infectious. So why did I get the InC3 group together? Well, it's highly infectious. It's all over the world, globally over 10 million people who inject drugs. And I had a cohort in San Francisco. It's just now ending. I've had a cohort of young injection drug users since 2000. And we have been measuring incidence of hepatitis C in these young people who are under age 30 for every year since 2000. And except for a few gaps in funding, it's constantly been at 25%, at 25 per 100 person years incidence rate. Compare that to HIV, where incidence, if it's 2%, that's like sub-Saharan Africa. Okay, 25% or 25 per 100 person years is really high. But you get 100 people who get infection, and it's not hard to get 100 people, and 25 of them will clear. Well, it's really hard to study 25 people. So I thought, well, we want to study these things, and I really, really saw myself in a vaccine trial one day. I said, so let's merge some cohorts. So we wanted to expand all of this because the outcomes become smaller and smaller numbers after a while, and we wanted to study these events and associations, clearance, reinfection, comparisons between groups like males and females, or men who have sex with men and non-men who have sex with men. So we needed a big database. And we needed opportunities to actually analyze data that you can't do with meta-analyses. So like with a meta-analysis, you get the meta, but you can't control for anything, right? So I'm going to tell you a little bit about the research that I've done about sex differences. We've done a lot with InC3, and I'm going to only focus on this for the most part. So, like I said, it's asymptomatic in 95% of people. Primary HCV, that says HIV, it should say HCV, are often not diagnosed, or they're misdiagnosed with some other viral syndrome. They don't seek medical attention, especially injection drug users. They often feel lousy all the time. So they're not out looking for that. Merging prospective studies was an idea that I had that would provide us more information on events, diagnostic, preventive and treatment strategies. I mean, when only 5% of your population is asymptomatic, you still need a big group to study those 5%. And they are different from people who are asymptomatic. So we started this meeting in 2009, and I got together a bunch of people who had ongoing observational prospective studies of people who inject drugs. And we conducted our first major data merge in the fall of 2011. And we had biological, clinical, virological data of 522 people with incident Hep C, from 8 cohorts. So our biggest study, one of our biggest manuscripts that I'll tell you about here, has actually been cited over 250 times since 2014. These are the collaborating institutions. My cohort at UCSF, which is called the UFO study. Johns Hopkins, Andrea Cox at Johns Hopkins, Arthur Kim at Mass General and Harvard, Julie Bruneau from University of Montreal, several investigators from University of New South Wales. We ended up with 3 cohorts from University of New South Wales. I like to say the Australians invented Hep C because they really didn't have any HIV, but they really pushed forward, and they're still continuing to push the envelope globally in treating and solving the public health problem. So we had a prison cohort, a MSM cohort, and a IDU community-based cohort. Burnett Institute in Melbourne. Amsterdam has some of the longest running observational research on hepatitis C of anyone in the world. And we were able to go really far back with data from that group. And we recently added data from my group. And this is sort of our global reach for the 10 cohorts that were there to begin with. We created a really cool website, and we envisioned that, and people can, I don't know if you probably can't, but right now our investigators can go in and query and just look for stuff that might help them figure out if this might be something they want to do or not, is there enough numbers, etc. So we merged the cohort data. Now this is not an easy thing to do. We all had different questionnaires. This wasn't an exercise in harmonizing data. to begin with. We had already done everything a priori. So we had to find the lowest common denominator of all these different things. Everyone's interested in blood exposure, how many times they inject, what do they inject. But obviously, people use different drugs in different places. Every epidemic is local, right? We've heard this. And that's true here too. But the heterogeneity could be really helping us to learn something. So we really wanted to do, we had 6 proposed studies. We got an R01 to merge this data and to move forward. And the international collaboration, the partnerships, every single person leading one of these studies, is a rock star. And we had to bring rock stars together and get along and have fun. And we did. It was really quite remarkable. And we had clinicians and immunologists and virologists, behavioral scientists, physicians, a modeler, people, epidemiology, thank you, all kinds of folks. So it worked. It was a really amazing collaborative study. We formed a scientific steering committee with governance. We set down some rules. We talked to other people who were running large merged cohort studies and learned a little bit from them. And we drafted some, papers about the publishing and documentation. And we had these teleconferences and the website that I showed you. So, we did all that, but really what everyone wanted to do was the cool science. The InC3 data coordinating happened at UCSF at the time, and we started off with one thing where we just looked at the acute infections, the new infections, but we have since expanded it to include thousands of people, including those at risk, so that we could study incidence. So today I'll tell you about acute infection, Hep C incidence, some of the protective factors, and what I've learned. I took an interest in the sex differences with Hep C early on, and they exist from birth to end of life, but this is only going to be focused on kind of early infection. So, like I said, we expanded the database, and eventually we had 2,175 people who were at risk of Hep C, and we could analyze things like incidence across these different places in the world. This just tells you how we included them and excluded them. Everyone had to have at least one RNA test without a subsequent, they had to have at least 2 tests, right? It's a cohort. And if we were going to study clearance, they had to have multiple tests because most people clear in the first 6 months of infection. But we had data on a lot of people, 2,000. In the USA, Canada, Netherlands, and Australia, about 2/3 or more were male. Most of them injected heroin, except in the Netherlands. And in the Netherlands, I don't really know what they were injecting, but methamphetamine was pretty prevalent in the States and in Australia. Cocaine use is pretty prevalent, especially in Canada. Heroin and cocaine combined. And then rates of having received opioid substitution therapy. It's not really showing up on the screen. So this is either methadone or buprenorphine at the time. And you can see that the Netherlands had the highest rate, but they started this a long time ago, and so did Australia. This is going to come up later. On average, though, the median number of years injecting in each of these areas ranged from 4 to 8. So, female sex is a major predictor of spontaneous resolution of hepatitis C. Early on, I found that women in our UFO study were 3 times more likely than men to clear. 33% would clear of the women and 11% of the men. And about the same time that we were learning this, someone discovered this polymorphism called IL-28B, which was found to be associated with medication-induced clearance of Hep C. That was when they were using pegylated interferon, an onerous drug chemotherapy regimen. But this funny little polymorphism and female sex, we also learned subsequently, were associated with clearance of acute primary infection. And this is from the InC3 study, where we found that women had a 2-fold higher hazard ratio of spontaneous clearance than males, and also was almost that high for people who were IL-28B CC homozygous. We also found, this is the big study, we found that women who were CC homozygous were even far more likely to clear than men who were CC homozygous, women who were non, and all the other groups. So 50% of women who are CC homozygous for IL-28B, aka interferon lambda 3, will clear hepatitis C infection. To this day, I don't think the mechanism for this is known. But I don't really do mechanisms, but I study this stuff, and it's pretty remarkable. I figure we have some immunologists who are on our team, and we are looking at some really interesting mechanistic factors that may influence this. It's all in the immune response. It's all in the genes. And so we are providing them with a lot of cells to study this. And that's not easy with injection drug users where you have to get a lot of blood and they have really bad veins. So our females who were interferon lambda 4, it's gone through 3 names over the last 10 years, interferon lambda 4, interferon lambda 3, IL-28B. If they're CC homozygous, they're 50% more likely to spontaneously resolve infection. So this was actually a really big finding. We showed it first in one cohort, and then we had all these other numbers, and we showed it. It was very robust, very robust. And that was the advantage of having the big cohort. We could start to look at other things like genotype, infecting genotype. Viral persistence, so this was infecting genotype, and what we see is that women who were infected with hepatitis C genotype 1 were also more likely to clear than people who didn't have that genotype. Now, the genotype, the virus itself, it's not known as just a host response or a virus or related to the virus, but you could never show this with a small cohort. It's interesting that different genotypes respond differently to different medications. So right now, with the interferon, in the interferon era, actually genotype 1 responded the least. And genotype 1 is the most prevalent in our remotely infected participants. So the baby boomer population here, 80% or more likely, 75% are going to probably have genotype 1. 1A, maybe 1B, but for sure going to be genotype 1. In our drug-using populations, we have a lot of heterogeneity, not only within the population, but by region. So in San Francisco, we have about 35, 38% with genotype 3. In New Mexico, it's about 40%, and in Baltimore, it's about 10%. So it varies a lot by what's circulating in the population. So this was striking and a very strong indicator of sexual dimorphism in hep C infection. And I began to look at the literature. When babies are born, actually males are more likely to get infected than female babies. But as life progresses, females don't progress with disease very fast. Males do until we hit the magic age of 50, and women then go downhill very fast and get liver cancer at the same rates as men. And this is globally. But what could I do in the InC3? So we also began to look at HCV RNA dynamics during early infection. And so when people get infected, there's basically 2 main patterns. There's a lot of variability there because we're humans. But you get infected and you develop chronic infection here, or you get infected and your viremia drops and you clear infection. And you can see the red lines, which are female lines, have slightly different patterns than men. What this doesn't show you too well is that, women, this shows you very well. It's not in chronic infection, men and women who don't clear look about the same. But in acute infection, women will have a higher peak viremia in early infection, and they will clear. Viral decay, if women are showing viral decay, statistically, we can predict that they are clearing, but we can't with men because they will bounce around more. Their viremic situation looks a little different. You can't really, I'll always hear a doctor going, they look like they're clearing. You don't know what it looks like because virus is in between here. It's bouncing around a lot. But median RNA in seroconversion period was very high. when you get infected with this virus, you don't get antibodies for up to 2 months. So I developed this really interesting way of detecting acute infection, which really has changed the game, where we test simultaneously for antibodies and virus. So, it takes 54 days to develop detectable antibodies, but you can have 7-log viremia for 2 months before you even know you're infected. This is when it's getting transmitted, more than likely, right? You don't detect it. You go in for a test and they give you an antibody test. They don't give you a viral RNA test. So I started using techniques that the blood system developed to look for just RNA, qualitative RNA, for $30 a pop. Back then it cost $250 to get an RNA test at the local lab. And we began to detect all this incident infection in these drug users. So that's how we captured them. This peak viremia is associated with more symptoms. People who are symptomatic are more likely to clear. People who are CC positive are more likely to have symptoms. Women are more likely. These things become all interchanged. So while I'm not really doing the mechanism, I've been saying we're now putting the pieces of this puzzle together. Early RNA levels are associated with, and high RNA levels above 5.6 log are associated with sex and gender-specific HCV innate immune response. Women will show a higher frequency of CD4-specific T-cell presentation, and that's really the key to our vaccine studies now is this cellular immunology, although neutralizing antibodies are making a splash. Factors independently, and this is the beauty of the InC3, is that we aren't just looking at descriptive data, we can actually analyze the data and hold things constant. But independently associated with high viremia is IL-28B, CC genotype, and being female. And there was an interaction here, which I don't show you here, but they are 11 times more likely to clear if they are women, or to have high peak viremia than men. So we kept going here. Non-drinking females also will clear more than compared to their drinking female counterparts and their male counterparts of both. Judy Sui did this again with InC3. We couldn't have shown this in one cohort, but we did find that about 40% of women who don't drink are likely to clear. So these are things that are modifiable. So it continues to add to what we can tell people. There were 2 big cohorts of women who were pregnant who got contaminated ROGAM during pregnancy, the Irish cohort and the German cohort. And those cohorts, the women were about 22 and 23 years old. 40 and 50% of those women cleared. So when you're when you're pregnant, you're usually not drinking. Age may have something to do with it, although we haven't seen that association. But they had a very high clearance rate in those ROGAM cohorts. This is just of interest. We have these 4 regions of the world, and you can see incidence. And I think it's very important to look here what happened in Amsterdam. Early on, they had a very high incidence of hepatitis C, and it's gone down to almost 0. The Netherlands was put in huge, comprehensive public health prevention measures very, very early on. I did my first year of my postdoc there in 1995. Yeah. And everyone was on methadone. Harm reduction was widespread. You could get medical care at the local, and needles at the local STI clinic. It was pretty remarkable. But what do we see here in San Francisco? We still see, and we've seen it forever, over 20 per 100 person year rates of infection. We also have very high rates up in Baltimore, and those rates have gone up in white injectors now compared to black injectors. And in Sydney, it's also gone down. What you don't see here is Canada, which has somewhat high incidence, actually. And that's because of the cocaine epidemic there. So when people inject cocaine, they inject a lot. The frequency of injecting is very high, so there's a lot of blood exposure. This is the proportion by region, and the proportion of incident in cases, this was like one of those data queries. Well, how many men and women are there who in these different regions who have incident infection? And I saw this funny little signal that more women had incident infection than men. Now, this could be due to our sampling. It could be due to many things. It was unknown. But in the general population, more men are infected than women. Oh, but more women clear. But still, and you still have more men infected, even if in some places the prevalence is just higher in men. So I had a student who did a meta-analysis. Now, this wasn't InC3, but we gathered, and we did a systematic review, and we gathered data from all over the world, and we did find that the female-to-male incidence rate ratio was 1.35. And in simple terms, they're 35% more likely to become infected than men. And this was from all over the world. You can see that the highest female-male incidence rate ratio is in China. China and Taiwan and some places in Asia have very high rates of hepatitis C. But across the board, the female-to-male ratio was almost above 1 every single place. Now, this is a meta-analysis, so what's the weakness? Well, we can't control for all these individual behaviors. And women have higher risk than men. On an individual level, women have differential risk exposure. They're more likely to use previously used syringes and needles. They're more likely to use ancillary equipment, the cookers and cottons that people use to prepare their drugs, where they can get contaminated. They're more likely to be injected by someone else, usually a partner, so they go second, right? And we showed this in our UFO study, and some other people showed it. We haven't done extensive behavioral studies at InC3. We also know that women in concurrent injection and sexual partnerships have the highest reported risk behaviors. So they have the most blood exposure. Women do. So a meta-analysis, we can't control for that. But in InC3, we can, this is data from the UFO study, the one in San Francisco. Women, the little red line here, whose male injecting partner is also their sexual partner, have a much higher risk of acquiring Hep C than women who don't have concurrent sexual and injecting partnerships. So this partnership thing is, I have a mentee who's been studying it, and there's all these issues of trust and, relationship issues that go beyond just the blood, which I like, but it's very interesting that they put themselves at higher risk. And this is true in many family situations. We're finding that in New Mexico. Whole families are injecting. So these partnerships, injecting is a very social thing. Very few people do it alone. So your social network, be it your family or your network, that might actually expose you to higher risk. So what we did was we looked in the InC3 study at HCV incidence by sex, and we could control for daily injecting, receptive syringe sharing, and these other things that we know women may engage in differentially higher than men. In that 2,000 people, we had 700 people who were eligible to actually be analyzed because we had to keep, we need a lot of data. And the HCV incidence in females was 16 per 100 person years. This is across all 10, well, there were 8 studies in here. And males was 7.6 with an adjusted female to male hazard ratio of 1.8. So it's not too different from our meta-analysis. We found these disparities in women existed across racial groups and across educational groups. And this is an area we have not studied yet, but we consistently see that people with lower education have higher incidence of Hep C. And this disparate higher incidence in non-white females is of a great worry as well. And this is going to be another area where we're moving into there's a PhD student in Australia who's going to be looking at sort of the social disparities in incidence between women and men. No, they have the highest. Females with the lower education have the highest. Okay. Across birth cohorts, women have higher incidence in the InC3 data. And we can go back pretty far because the Dutch had all this old data. Here was an interesting finding in that study. It was published in CID, but this incidence rate ratio seemed to be really disparate in people who received medication-assisted treatment for opioid use disorder. Medication-assisted treatment for opioid use disorder is one of the most efficacious ways we have of reducing Hep C incidence. In our study in San Francisco, we found that it reduced Hep C incidence in the cohort by 50 to 60%. If the vaccine that we've been testing does that, it's going to be, bonkers. But we have stuff that works if we can get people into treatment. This is a meta-analysis that was conducted by Lucy Platt using data from its Cochrane analysis that was recently published, and they found across all studies that had this longitudinal data that medication-assisted treatment, also called opioid agonist treatment, also called MOUD nowadays, it's just treatment. Treatment for opioid use disorder reduces incidence by 50%. Syringe service programs reduce risk by 56%, but only in Europe. And MAT and SSP jointly reduce risk by 71%. So we do have some things here that work. But we saw this little disparity, and even in this meta-analysis that Lucy Platt did, for every 10% increase in women in the population, the protective effect went down. What is that about? This just shows you that same data. The Hep C incidence decrease here is the highest combined, right here, where is it? Low NSP versus no NSP, you have the highest, the lowest incidence decrease. You have a 50% decrease in incidence with combined NSP and OST versus none. These are really important. If my vaccine does this, I'll be amazing. So we know that OST protects from Hep C, and this is InC3 data that is in press. Except for we only analyzed the women in this. This was presented, but I wanted to show you the difference between males and females. Women who have never accessed MAT versus women who have accessed MAT, those they all have a lower incidence. They all have a higher failure rate than men, and women who have never accessed MAT don't do very well either. So why this differential? Women have kids, maybe they don't go to methadone if they're required to show up for daily dosing. We've learned a lot. Actually, there are some interesting pharmacological differences in how MAT affects women and men, but we only know about that during pregnancy. It's never actually been studied outside of pregnancy. We do give women who are pregnant and have opioid use disorder buprenorphine or methadone, but we don't really know if there are sex differences in some of the pharmacokinetics outside of pregnancy. And it's important to know that in pregnancy, and we're really glad that women can get access to this. But why are women less protected? And it may be a combination of behavioral, structural, and biological factors, similar to the higher incidence rate. It's probably not just biological, but a combination of structural and social factors that contribute to this. Even when we control for things in those analyses, we're probably not getting everything. So the factors that are associated with decreased efficacy of exposure to opioid agonist therapy in females compared to males are stable housing, although men also have, if they are unstably housed, they're highly likely to not have very effective OAT. But the big one for females is receptive syringe sharing. And women still, again, show this differential risk exposure. They're more likely. So even when people are in methadone or on buprenorphine, they may continue to use drugs. We recruit people who are using drugs from our methadone clinic for one of our studies. And this speaks to the dosing problem. If you're not adequately dosed, you will continue to use. It may do less harm. You may have some protection because that's really the mechanism, is reduced frequency of injecting. But we need to be examining some of those things that are, how are we underserving women in terms of their risk and their protection? In our vaccine study, we actually stratified our randomization by sex and IL-28B. So, bottom line is, women who are exposed to OAT are twice as likely to acquire Hep C infection than their male counterparts. Even though they're protected, they only get half as much. Structural and behavior interventions that target women are needed to really bolster the efficacy of this. And as OAT is expanding across the country, and we do need to be looking more at, are women getting adequate dosing? Are they getting the structural factors that they need to support them getting it? You know, I was on a call the other day and they said, so how many, do you have childcare in your clinic? He goes, we got kids here all the time. But someone else said, oh no, we don't have kids. If they can't bring their kids, you're not going to come back. We need harm reduction services that are sensitive to the needs of women specifically. And when I talk about harm reduction services, I'm talking about services that are in the community that specialize in prevention, like syringe service programs, or overdose prevention, counseling, testing. And we have to look at what other factors or maybe other mechanisms that are attenuating the protective effect among women. Unfortunately, we have no medication for methamphetamine. A third of people are using methamphetamine. They're getting infected too. So we still need to go a long way in all of these. Women compared to men who inject have a 38% higher risk of incident Hep C. Factors that are protective are attenuated in women. There are other disparities that need attention, including race, ethnicity, and education. And the natural history of Hep C varies by sex. A larger proportion of women versus men clear, which is good news. But I will tell you that they also get reinfected. And I didn't show you any of that data. They do get reinfected. The good news is that if you've spontaneously cleared, you're more likely to clear again. So we have a lot of women walking around who are quite protected. But eventually, I've seen people, get infected 5-6 times, and then it sticks. We don't know why. Women have different viral kinetics in early Hep C infection, pointing to different immune responses, and this is important to know for vaccine development. We need to study female sex not as a confounder, which it often is, but as a biological and a social factor, and also look at structural factors as well. So the InC3 did a lot of work, 3 rounds of data merges with tons of people and over 11,000 person years of follow-up. We had 19 published papers and 3 that are currently in proposed and a few that are in press now. And we are no longer funded. We ended our funding. We're going to try and renew this. We formed a lab group. We have samples from across the globe in a lab in Australia, a viral specimen and sequence repository, and we've sequenced all the viruses from all these different places and have a really informative group there. Our plan for the next submission is to add 10 more cohorts. I know. Enhance the sample size and do research in new directions. I still want to continue to study differences between males and females. We're doing some hormonal work because that interacts with immunity, and study reinfection, especially right now in the DAA era. But we think that these kinds of studies can really inform public health. So our next iteration will be to continue to study infection, but also to look at the outcomes of direct-acting antiviral infection. We have reinfection after treatment, and it's probably not protective as it is with spontaneous treatment. We have all kinds of different things that we need to study. And biologically, I think hormones, lipids, genes, and immune responses are going to help us a lot. This is what the map should look like in the future. And we still really all like each other. We are hoping to continue to expand. I've got one more group that's interested in joining us from England, and so that would be good, but we don't have anyone from South America. And that's the end of the InC3 talk. It's been a long history of work, but it all started with putting together a really great collaborative group of investigators with differing interests, overlapping but differing interests. And we also brought different strengths to the collaboration. Some people had PhD students, some people had MS students, some of us had med students. And so it really did grow across communities and the globe. So thank you very much. Oh, good. I talk fast, but questions?
Yeah, amazing talk, super interesting work. I was wondering about, so you use the terms gender and sex interchangeably?
Yeah, I really like the word sex.
Yeah, so is that what most cohorts are actually collecting data on?
Yeah.
It's really hard, I mean, especially here in Colorado, we don't even have a way to, well, we didn't until this year, to measure transgender outcomes. But is there any distinction between transgender individuals? I mean, I know you talked about looking at hormonal work, and that could certainly be relevant for transgender individuals on hormones versus off hormones, and we know that transgender individuals are, more at risk for HIV and most global diseases. So I just want to hear your thoughts.
Those are really good questions. I was personally interested in sex as a biological variable, and so I didn't look at gender, but we do have some cohorts who ask, how do you identify? And we are able to look at that in some of our behavioral studies. I think that the only way we're going to be able to answer some of those really important questions, because the transgender community is at higher risk for bloodborne infection, is with merged cohort studies like this. And if we grow, that would be a really big potential area to grow in. Interestingly, all of our cohorts in Europe, though, we collect no race ethnicity data. It's against the law since World War II. We don't know what their race ethnicity is. So there are strengths and weaknesses in data collection everywhere, including Colorado.
Yeah. So you would say that, generally across the cohorts, though, it's referring to sex?
Yes, but some cohorts do collect how do you identify in your gender. And so we do have some of that data. And it has not been looked at, which is a great idea. Thank you.
Thank you. That was a really interesting talk. It seems like it's challenging to follow a cohort in what that cohort looks like, right? It's expensive. It takes a lot of effort, a lot of person power. And I would think that this cohort in particular has challenges with follow-up. So how do you maintain that follow-up? What are some of the things that you found that work? And I don't know if you have some data on what you follow up with.
So I have a cohort of my own that was a member of the InC3, the UFO study, and it's very expensive to follow our people who are injecting drugs. They get lost, they go to jail, they die. You don't even know that they're dead. It's really hard. We had to do that in the vaccine trial, too, at 2 sites. It's really hard, and it's boots on the ground. We also use social media and phone calls, money, pound the pavement, it's shoe leather, literally shoe leather epidemiology. But we tested GPS devices. That was fun. And people tried them out, and we had focus groups about whether they thought, they were being, what they thought about it. They weren't really afraid of the man, and they worked because the GPS devices weren't worth anything. So they couldn't really sell them for anything. So that worked pretty well, but it would take something to have everyone carry a GPS device. I don't know how practical that is. In general, these cohorts have only a 70% unadjusted follow-up rate is really good in an injecting cohort, and you can do your magic, like death and termination, and adjust it up a little bit, but it's a real challenge. And so running a clinical trial in a cohort where you're going to lose more than 10% is also a challenge. Each one of these cohorts was independently funded, and we're always fighting for funding. And I don't know. I was told that NIDA wasn't going to renew our cohort no matter what. Maybe now they will. They might want to. I don't know. Because these are subject to political things too. And but now with the opioid epidemic, it might be possible, except they're interested in rural cohorts. So I started a cohort in Rio Arriba County in Espanola, and there we have pretty good follow-up because they don't move. And we're finding a lot of cool new things. So it's different. It's really hard. Yeah. And the losses here, the missing data, is something that we have to always deal with in our analyses. So we've done that several different ways.
So did you have differential follow-up, different loss between men and women, or was it similar?
No, we didn't. We didn't. Luckily, we checked that. We got asked that. Not that we could tell. Yeah.
Do you know what case definition is being used across these cohorts for acute HCV infection?
Okay, we used 3 different definitions to define acute infection. One was having a viremic seronegative test, where we knew that they hadn't been exposed and we had confirmed RNA. And we usually had to have another test too that showed ongoing RNA. A couple of these cohorts had what we call opportunistic cohorts, and they were brought in as symptomatic patients. So they were jaundiced or icteric or had a fever. And remember, only 5% of people who get the virus are symptomatic, and they're special. They clear more, but we do have some symptomatic cohorts. One is in Boston. Arthur Kim's cohort is a symptomatic cohort or opportunistic cohort, you know, what a doctor can find that walks in his office. And there was some in Australia that were symptomatic as well. And we used the criteria that they use in those studies, which basically had to do with having risk. Because some of them came in viremic, but they had a previously antibody positive, but they might have had a previously documented negative, or they had to have symptoms consistent with hepatitis C, no Hep B, no Hep A, and the symptoms that were in that. And the others were just your straight up seroconverters who went from antibody negative to antibody positive, and then we were able to get blood and test their RNA later. So different people did a different way, but there were 3 different ways.
Cool, thanks. Yeah, I'm just interested in that because, like, in the graph that you showed from CDC, that goes up to 2017, or I think it was 2014, the case definition in the US that CDC uses changed dramatically. So actually some of that increase that we're seeing in 2016, well, I work in the state health department and used analysis to see how many of our acute reported cases would have met the 2015 case definition. And we had, I think, a 35% reduction in what would actually be reported acute. So from 2016 to 2017, we can compare those numbers. But 2016 to 2015 using CDC definition, it's hard. So.
Oh, let me scare you even more. Arthur Kim, who you know, in Boston, Massachusetts has the best electronic medical record in the country, right, across the state. So he's got this opportunistic cohort of people who present clinically with acute infection. 100 people. They publish this paper. How many of them got into the system? How many of them got reported and ended up in the acute database at CDC? 1. The CDC uses a multiplier method to estimate what the actual burden of disease is, and I think it's 17. So for every acute case, they estimate that 17 more have gone undetected, and so that's what they use.
Yeah, I definitely think
Right?
It's really interesting. I wonder if it's based on the ALT levels.
ALT levels are often used,
Yeah.
but in our case, they had to have a previous negative. And no evidence of Hep B or Hep A.
Oh, yeah, that's important.
That's a really important one, too.
Yeah. Thank you.
Thank you. I love this virus.
Did you cover differences in access to treatment?
We did cover differences in access, and we ended up doing a really interesting merged analysis early on with some groups. The Australians were treating like crazy. The U.S. was not, because it was still interferon, and if you were a drug user, no one would come near you, because there was a lot of contraindications to pegylated, to interferon-based treatment. A lot of contraindications, which for good reason, people were excluded from treatment. In Germany, they were treating like crazy too. And when I first started my career in acute Hep C, I mean, I started studying Hep C when the antibody was first developed, and we tested it in our population-based cohort of MSM in San Francisco. But then later I got into it, and you can estimate incidence from these seronegative viremics. There's a lot of cool stuff that we can do. But nobody had access here in the States. But if you treated acute infection back in the day, you had a 95% cure rate with interferon. Right. But no one would come near us. I still can't get a hepatologist to step inside of one of my field sites. I can get family medicine, I can get all kind of ID docs, but I can't get a hepatologist to walk into a field site that's full of injection therapy. But we work with them anyway. There's a few exceptions. Greg Dorr in Australia, Arthur King. He's an ID doc, not a hepatologist. Yeah. But now the access is really changing. And of course, what we're seeing is a lot of people getting treatment who waited, and now the treatment rates have fallen off because they're not being identified. They're not getting tested. That's our newest challenge.
So I have one more question. So that's can I ask?
Of course. Okay. Now, someone else. Does someone else have something? Okay, go ahead.
I was really interested and surprised to see that other opiate was so low, like 1% in the U.S. for percentages of drugs injected. I was wondering what the source of that data was.
Well, in San Francisco, Opana is not even on the formulary. Okay? And besides, it costs too much money. You can get a dime bag really cheap of heroin. And so a lot of people they're not using injectables. Prescription opioids. Now, in Canada, there's a lot of prescription opioid use where they're, carving it up and injecting it, and that comes with a whole series of issues. In Kentucky, that's what's been happening. In Indiana, that's what happened in that big HIV outbreak. But in many places, you still have black tar heroin, and if you haven't read it, do read Dreamland and learn not just about the pharma industry, but the industry of black tar heroin as it happened in the U.S. But we have black tar heroin everywhere. On the East Coast, you have crystal white powder heroin, and it's so much cheaper than a pill. So we don't have that much overlap. But people will inject bourbon if they think it will work. All right. Thank you.
Thank you.